you will, eaten into about 10 minutes of the time that's been allocated. And so we will move through our presentation as quickly as possible. And we've also been reminded that in order to assure that everybody has lunch and is seated for the lunchtime presenter, that we will be ending just a few minutes before 12 noon. So that's the framework. We hope to move through the presentation quickly enough to allow questions from the audience. So thank you, and welcome to Medicaid 2.0. As I reflected on that title, however, this morning, I thought maybe it should be Medicaid 5.0. It has certainly been an ambitious 3 years, but most importantly, the last year has been an ambitious year for the Department of Human Services MedQuest division. Presenting this morning on behalf of MedQuest is Ms. Patty Bazin and Dr. Kenny Fink. Patty, as many of you know, heads our healthcare services branch. In short, she oversees all health service contracts issued by MedQuest. She also drafts the RFPs, coordinates the RFP responses, and the selection process. Buried into that rubric, however, is Patty's commitment and vision. And everything she touches and looks at, she is always thinking, how can we improve services? How can DHS improve access? How do we improve quality? How do we promote transformation? And how do we reduce fragmentation? Dr. Fink, Kenny as he prefers to be known, is the MedQuest Division Director or Administrator. Kenny has been at the helm of MedQuest as we have accelerated from MedQuest 2.0 to 5.0 over the last several years. So he and Patty's presentation this morning will crosswalk with you many of the innovations and changes that MedQuest division has witnessed over the past several years. I think it's been transformative. I think from a director's perspective, even just standing up the KOLEA system in a 10-month period of time, a system, by the way, that is on time and works, was nothing short of miraculous. In addition to KOLEA, we have integrated behavioral health and worked with the community, we hope, to improve and reduce bifurcation of services. We're also moving forward to Quest integration, which Kenny and Patty will tell you more about. I did put Kenny on the spot this weekend, however, when I was made aware that the Commonwealth Fund recently named in the September report Hawai'i as #1 in healthcare systems performance for low-income populations. And I think that that's a cause to celebrate, that Hawai'i, of all the 50 states, is #1 in the delivery of healthcare for our lowest income. So, while I appreciate the applause, I think that the vision for that has to be attributed to the governor, has to be attributed to Beth Giesting and her transformation efforts, as well as to the hard work by our MedQuest team. So without further delay, Dr. Kenny Fink.
And very much want to recognize Dr. McManaman for all of her leadership. Obviously, everything we do is under her leadership as a division in the Department of Human Services. We have a lot of content, so we're going to move kind of briskly through here. Patty and I are going to do a couple of do-si-dos as we share this presentation. So kind of the overview, we're going to go over transformation activities that have been implemented, are in progress, and some future planned or potential opportunities. So some of the implemented transformation activities include public reporting, financial incentives, value-based purchasing requirements in our health plan contracts, performance improvement projects alignment. These are a requirement of our health plans to perform, and also some transformation regarding long-term supports and services, where we have really rebalanced the delivery of these services. So for public reporting, we've created a consumer guide of health plan HEDIS and CAHPS scores. This is available on our website, and we distribute it during annual plan change. So we heard earlier today the importance of information so our beneficiaries can make informed choices. So we're trying to be transparent about the performance of our health plans and to better inform our consumers so they can make better choices. Annually, we have an external quality review organization technical report. Having an EQRO is actually a requirement of the Medicaid program. And this technical report is available on our website where you can go into great detail about how our programs are performing. In addition, we have reports to the Centers for Medicare and Medicaid Services. There's an annual report. We have to do an evaluation of each 5-year Section 1115 demonstration waiver. And those are also available. So we try to have increased transparency in how we do. Another transformation activities I mentioned is the financial incentives, which we started in the QUEST program. There's a $2 per member per month incentive that is available to our health plans based on our performance. There are 5 measures and each is weighted equally. In order to earn the financial incentive, you can see the threshold that the health plan has to achieve for each measure to earn that incentive. And these are the 5 measures: childhood immunizations, chlamydia screening, controlling high blood pressure, comprehensive diabetes care, and getting needed care. And we'll present some results in a little bit later. The value-based purchasing was also something that we initiated in our health plan contracts, and it requires the QUEST health plans to align payment with quality and efficiency. The following are the domains that must be addressed. So patient-centered, accessible, comprehensive, coordinated, evidence-based, and performance measurement. And the requirement applies to both primary care providers and the hospitals. So we've had an increasing percentage of provider networks that are required to be on some value-based purchasing contracts. So in year 1, it was 10%, up to 40% by year 3. And we think this is important to advance our delivery system. And embedded in this is the medical home. So the medical home is a key aspect of starting to align payment with performance based on those domains. As I mentioned, the PIPs are a requirement of our health plans. Oops. And before, the health plans could choose, but we've really wanted to align those efforts, because you will have a provider in the community who may be participating in numerous health plans. And to sort of have some administrative simplification and get some synergy to have the plans working on the same area really makes it easier for the provider, and we also hope that it will have a more significant impact. Some of the PIPs that we have now, all-cost 30-day readmission, trying to reduce the rate of that, to improve diabetes self-management and disease management. And then we've also allowed a choice, though, of childhood PIP, of childhood immunization or well-child visits. As we go into QUEST integration, there will be full alignment. So the QUEST program has been existing since 1994, QXA since 2009. And with the QUEST program, it's just more developed that we've rolled these things out. But as we moved into QUEST integration, it will apply equally across the entire medical assistance programs. Now Patty's going to share some data.
So thank you for allowing me to share how our health plans are doing. So the first thing I want to go through is some of our HEDIS measures, and the first is reduced emergency room care. One of the things that's very confusing about this measure is that it's the lower the score, the better. So everyone looks at this and says, oh, look how poor the health plans are doing. Actually, our health plans are doing excellent. This lower line right here, let me see if I can get my pointer to work. Not so well. But anyway, so our lower score, this 10th percentile, this shows that we're within the top 10, lowest 10% of the country. So we're actually doing 90% of the country is worse than we're doing in Hawaii. So that's very, very good for emergency room care. The next moves into childhood immunization. And as you can see, we do have room for improvement. So we have the blue line, which is our 50th percentile, and the 75th percentile, which is our red line. And we do have room for improvement. But as you can see, our health plans incrementally are getting better every single year. And as we're starting to put financial incentives in place, we're starting to see more and more improvement. So from 2012 to 2013, we've had a 2% improvement. And you think 2%, is that really a lot? We have 150,000 kids. So improving by 2% is actually providing quite a bit more immunization for those children. The next is our chlamydia screening, and we are actually at the 75th percentile. So the 75th percentile is 63.7, and that's where the state of Hawaii is. So we're actually at the 75th percentile for HEDIS for chlamydia screening. The next is controlling high blood pressure. So this is a brand new, HEDIS measure we really started looking at in 2013. And as you can see, when we start looking at it in 2013, we've seen an improvement from 47.1% to 51.3%, which is actually a pretty good jump for controlling high blood pressure. Controlling high blood pressure is keeping blood pressure below 140/90 when somebody goes in and sees their doctor. So we feel like this is a good improvement. Once again, we still have room for improvement, but little by little our health plans are making improvement, and they're doing this with their providers that they're providing services with. The next is improved diabetes care, and this one screen we're looking at. Improved diabetes care has multiple different types of measures you can look at, but this is hemoglobin A1C lower than 8%, and we've seen a bump from 39.6 to 43.3%. Still not at the 50th percentile, but we are seeing improvement, and this is a new measure that we put into place to look at in 2013. Improved CAHPS results in Quest. So one of the things we do is we do a CAHPS survey, which is a client satisfaction survey. How satisfied are our clients with the services they're getting? And there's a child survey, there's also an adult survey. And what we're looking at is we're looking at the children's side, because the children but we've come back up in 2013, so we're kind of where we were in 2009. We're hoping to see this getting needed care get higher. So this is what parents are saying, are my children getting the needed care that they need? And once again, we do have room for improvement, but we are doing better. This is our QXA. And this was our Child's CAHPS survey. And the first year we did Child's CAHPS in 2011, our score was pretty low, but we've had a huge improvement in QXA of parents saying, yes, my children are getting needed care. And so, one of the things we do is we don't just expect our health plans to just get these results and just go, oh, what am I going to do with this? We actually expect them, how are you going to improve on this? And in QXA, we have seen some improvement in the past 2 years for child. The next thing I wanted to talk a little bit about is our rebalancing of long-term services and supports. So this is long-term care. This is nursing homes, home and community-based services. And we don't spend a lot of time talking about this, but in QXA, this is one of the things that they've really been focused on is, increasing home and community-based services. So if you look at our numbers, we've had about 2,000 more people receiving long-term services and supports since 2008. And, we started QXA in 2009. And what you can see is if you look at the green bar, this is home and community-based service clients. So this is people receiving services in their home or community, and the yellow is people receiving services in a nursing facility. So what you can see is that nursing facility is coming down and home and community-based services is going up. And this is really a trend that is going on nationwide, but we're really pushing in Hawaii because people would rather receive services in their home if they can, and we want to make that available for them. And then what you can see is our percentage of home and community-based services. So you can see that, we started QXA in 2009, 2008. We wanted to give you a baseline before we started QXA. There was very little change between 2008 and 2009, but we had a big jump in 2010 when our QXA health plans really started making that transition from, nursing facilities to home and community-based services. And, we're really kind of going up a little bit each year, maybe 1%, but, we still are moving in the right direction for home and community services. So I'm going to turn it over back to Kenny now.
Okay, I think we're going fast enough that we've caught up on our time. Slow down a little bit. I know we're flying, sorry. So as a result of the quality improvements, the rebalancing of long-term care and improved efficiency, we've actually have a savings of $2.4 billion over the lifetime of the program. Now, this number is actually calculated by the Centers for Medicare and Medicaid Services, and there's a requirement of, it's called budget neutrality, that when you do a Section 1115 demonstration waiver, which allows you to test certain things, such as using a managed care delivery system, or to expand coverage to other populations, or cover home and community-based services. The amount you spend under that demonstration cannot exceed what you otherwise would have spent in your fee-for-service program. So CMS is very careful in monitoring how much you're spending under that waiver. So this is actually the cumulative savings according to their calculations. The yellow is actually state funds, so it's $1 billion of state funds that the program has saved, and $1.4 billion of federal funds. Okay, so some transformation activities that are in progress. The primary care provider reimbursement enhancement, Medicaid eligibility changes under the Affordable Care Act, behavioral health organization implementation, Quest integration, and health information technology. Let's go into those. So the Affordable Care Act included a provision, actually a requirement, to increase reimbursement to primary care providers in the Medicaid program such that their reimbursement is at the Medicare rates. Medicare rates are roughly 50 to 60% higher than Hawaii's current Medicaid rates. So that's a significant increase in reimbursement. To be eligible, providers have to attest to meeting certain criteria. And there are 1,000 providers in Hawaii who self-attested prior to June 30th, 2013. We made an initial payment, which was retroactive back to January 1st, so it covered that 6-month period of this calendar year. And it was an enhanced reimbursement of over $10 million that went to our providers. So, we greatly appreciate the providers that have been participating in the Medicaid program. All of the success you've seen with the improvements we've had in our quality of care is really attributed to our providers and other partners. And it's wonderful that we are able to provide this additional funding, which is 100% federal funding. And we actually have in our budget to continue reimbursing primary care providers at an enhanced level. One of the reasons for having the enhanced reimbursement was that in expanding coverage, you want to ensure that you have access. So my understanding is that by reimbursing primary care providers more, you would hope you would have greater access. So it's difficult to measure our providers accepting more patients as a result of increased reimbursement. But we do know that there are 53 new provider health plan contracts since this went live. So there does seem to be some effect of providers being more accessible. Okay. So with the eligibility changes under the Affordable Care Act, Hawaii has expanded eligibility. Last week I was attending the National Association of Medicaid Directors Conference, and there are a lot of states that even now are not sure if they're going to expand Medicaid. And I felt quite fortunate that that was never an issue here. We always knew we were going to expand Medicaid, and how lucky we were, how lucky I am, that really wasn't a problem. Other changes, again, as required by the Affordable Care Act, are converting income to this modified adjusted gross income, or MAGI. And Hawaii has been an early adopter with the MAGI conversion effective October 1st, with the Medicaid expansion effective October 1st. These changes are not required or allowed really until January 1st of 2014. So as an early adopter, we actually had to go and get special authorization to be able to be an early adopter. The way we could be an early adopter was actually through our Section 1150 demonstration waiver. So we executed a 5-year renewal, which was effective October 1st, and included that authority to be an early adopter. This demonstration waiver is called the Quest integration waiver. To be able to implement the Affordable Care Act, it required 28 state plan amendments to date, and there actually are a number of additional state plan amendments that are required, so there's still a lot more work just to implement the Affordable Care Act. And we have fundamentally redone our administrative rules. So we have, hopefully it is more logical, it is more transparent, and really easier for the public to understand how we operate our program. Okay, MAGI. The intent of MAGI was to yield comparable thresholds of what we currently have in the Medicaid program, so no one would lose eligibility due to the conversion to MAGI. The groups that are subject to the MAGI income methodology include children, pregnant women, families, and certain adults. It does not affect eligibility for aged, blind, or disabled individuals. So ACA did not change eligibility criteria for aged, blind, or disabled population. So when you see this conversion for these groups, the current income limit, this was current actually as of prior to October 1st, but this was after disregards, what their income threshold had to be. So in the conversion, it took the value of those disregards and added a percentage to the MAGI, which is why it's above 300%. And then in addition to the conversion, there's this oddity where people get an extra 5% if that is the category that they would not otherwise be eligible in another category. So the conversion for children went from 300 actually to 308, but with the 5%, it's 313. Again, pregnant women went from 185 to 191. The extra 5% got them to 196, et cetera. The key change in the expansion was the elimination of the asset limit for those groups. So children and pregnant women did not have an asset limit to begin with, so there was no change. But actually the parent caretaker relative group had an asset limit, and the childless adults, which we covered as an expansion group, had an asset limit. So the real effect of the Affordable Care Act and Hawaii being a Medicaid expansion state was removing the asset limit. We already covered these adults up to 133% of the federal poverty level. So we didn't expand by income, we expanded by removing that asset limit. So to put into a little bit of context, when you saw those incremental changes in quality, understand that we experienced a 38% increase in enrollment during that period. So it wasn't just improving the quality for a fixed population, but it was serving an additional 38% of individuals, or over 80,000 new individuals. So that's what I think is real impressive. It's not just the quality, but it was concurrent with the huge growth in our enrollment. So you can see here how our enrollment has increased. Now, we did project under the Affordable Care Act a 48,000 increase in enrollment over the next year. And we're just going to continue to observe how that enrollment trends out. So we implemented a new eligibility system. We were able to receive 90% federal matching funds, and this is the first new eligibility system in about 25 years. It is a massive, massive undertaking, both for us, and it impacts you as a community. People need to get familiar with the new system, and along with this system, there'll be new business processes. So we're working on this together. Eligibility systems typically take 3 to 5 years to implement, and we had to pull this off in about 9 months. So although we got something up in time, there's a whole lot of work to be done. The system will support the MedQuest division, or the Department of Human Services broadly. MedQuest is going to come first, followed by Bazin and the Social Services Division. And we're really leveraging this opportunity to more broadly serve the state. So this is the website. The application process, you heard a little bit about earlier, so real quickly, individuals can apply for financial assistance, and if they do not seek financial assistance, they'll go directly to the connector. The application will come in. We will try to verify the information that's provided through the federal hub. The intent is to make a next day determination if data can be verified. If individuals are not determined eligible for Medicaid, we'll send their information to the connector, and the connector will determine their eligibility for advanced premium tax credits. So a Medicaid eligibility determination is not required to receive a tax credit eligibility determination under federal law. The federal law says to be eligible for advanced premium tax credits, you simply cannot be Medicaid eligible. In Hawaii, we've created a sequential process to ensure that those who are Medicaid eligible receive services as quickly as possible. This slide was presented earlier, so I will skip that and pass it on to Barry.
So I'm going to talk a little bit about our behavioral health organization implementation, which is something we've been working on for the past, 6-9 months or so. So we have revised our the way we're providing behavioral health through MedQuest Division. And we did this to, provide more services to our beneficiaries, and I'll go over those services in a few minutes, ensure clinical continuity, simplify the system for navigation for our beneficiaries, and I'll show you some slides in a little bit that show you how complicated it was and really where we're headed. Improve the service delivery integration, reduce administrative burden for providers by being a more efficient and effective system, improve efficiency of our state programs, and then to optimize federal matching funds claiming. So the first 5 diagnoses or diagnoses we've been covering under DHS for specialized behavioral health services for a long time, schizophrenic disorders, schizoaffective disorders, delusional, mood disorders. But we've recently added October 1st 2 new benefits. One is substance-induced psychosis, and the other is post-traumatic stress disorder. And we're very excited to be adding those benefits, adding those diagnoses to be able to cover those services for our beneficiaries. We also have, this is a list of all of our behavioral health services that we provide. I mean, most of the ones that I think people are pretty comfortable with: psychiatric hospitalization, ED visits, emergency department visits, psychosocial rehabilitation. But we're recently adding new services, and those services, once again, are effective October 1st. And that's peer specialist, clubhouse, supported housing, which is kind of a case management to help people find housing. Financial management, where some people know as oh God, how did I forget that? Representative payee. Thank you, Mari. I appreciate that. And then supported employment. So those are benefits we just put into place. So we're doing this through our Community Care Services program, and CCS has been a program that DHS has had since 1994. So we've had this program for quite a bit of time, but as most programs do, it's evolved, and we're really trying to make it more usable and user-friendly for not just the consumers, but also for the providers. So it's a DHS program that provides specialized behavioral health services. We're now making it a full capitated risk program, so it has all the services that are available, and we're paying a capitation for that. We're requiring the vendor to actually coordinate with our health plans, so that we're trying to coordinate the medical and the behavioral health side, and our current contractor is Ohana Health Plan. And they're currently serving about 4,500 members, which is I think more than we've ever served in CSS before. So I wanted to show you the delivery system. So if you look at this slide, and this is what we were doing prior to September 1, you can see Quest and QXA, 2 different programs. Quest is much more streamlined because they're doing the standard services, which are those acute hospitalization, psychiatrist, psychologist, and then those specialized services, which is more of the, psychosocial rehabilitation, case management, those types of things. Under QXA, it was very complicated. I mean, the standard services was from QXA, but then the specialized services, some was being provided by Adult Mental Health Division, some were being provided by CCS. Providers had no idea if someone was in Adult Mental Health Division or CCS. Very confusing for everyone in the community. I don't even know that the consumers knew who they were receiving their services from. When we implemented and we actually moved about 3,200 individuals into CCS effective September 1. We're trying to make it so that if you're in QXA, you're receiving all of your specialized behavioral health services through CCS. And we're trying to make that a more streamlined system, easier for our providers. They only have one place to go if someone's in QXA, and easier for the consumer as well. Our next phase is we're going to take individuals out of their Quest plan and we're going to move them into CCS as well. And the reason for that is that we find that if someone's in Quest receiving those specialized behavioral health services, especially if someone goes to a provider, the provider has got to figure out, okay, are they in Quest, are they in QXA, are they receiving this from their Quest plan, are they receiving this from CCS? Still very confusing for the providers, maybe a little less so for the consumers, but we're finding if we move everyone into CCS, DHS, if you have Medicaid and you're receiving specialized behavioral services, you have one place to go. So we're thinking that's going to be a more efficient and effective system. And then once again, CCS coordinates with the health plans for the medical side, so there's a coordinated medical and behavioral health benefit. When we do our Quest integration program, January 1st, 2015, if someone needs specialized behavioral health services, they'll just receive it through CCS, and, we'll only have, Quest integration. We're not going to have Quest in QXA, and folks don't have to determine, am I in Quest or in QXA? So that moves us into Quest integration, which we're very excited about. This is a big project. And Kenny mentioned that we have our 1115 waiver approved for Quest integration. That is correct. We're also procuring to move managed care into Quest integration. So let me talk a little bit about that. So why are we doing Quest integration? We're trying to do a patient-centered approach with provision of services that are based upon clinical conditions and medical necessity. We're combining our Quest and our QXA programs. We're trying to do this for convenience of the client as well as convenience of the providers. We're eliminating our Quest ACE and our QuestNet programs. And we're trying to do this so that our beneficiary remains with the same health plan, whether they turn 65, whether they have a health condition. Today, if someone's in Quest and they have a stroke and they need long-term care services, now they need to move into QXA. It's very confusing. When things are the most complicated, now they're moving. We're thinking this is going to be a better process for our beneficiaries. So our health plans will provide a full range of comprehensive benefits that include long-term services and supports. Some of the changes we're making in Quest integration is we're actually lowering the ratios for service coordination so that, our service coordinators will have less individuals that they have to work with, as well as we're going to be providing some home and community-based services to at-risk individuals to help them prevent decline in health status. So what is the timing for this? We're in procurement right now. We received proposals November 1st. We're scheduling contract award for January 6th, and we're going to be implementing January 1st. During the whole year of 2014, we're doing readiness review to make sure that our health plans are ready to take on that population. But there are some things we're implementing prior to January 1st. And, one of those things is we did a non-long-term care retro eligibility increase from 5 days to 10 days. So basically, when someone submits an application, that goes 10 days prior to them submitting the application. So if there was a hospitalization or, emergency department visits or doctor's visits, that can be covered up to 10 days prior. We are still keeping the 3-month for long-term care, which we've had for a long time. We're also implementing our at-risk population receiving home and community-based service benefits January 1st of this year, and that's a project that we're very excited about. And then we are going to do that consolidation of all specialized behavioral health services into CCS April 1st, 2014. So now I'm turning it over to Kenny.
So health information technology deserves far more than one slide, but for sake of time, I'll just show you a little bit what we're doing. So there are two electronic health record incentive programs. There was a Medicare incentive program and a Medicaid incentive program. Under the Medicare incentive program, Hawaii has received $37 million, which was paid to over 900 providers. The Medicaid EHR incentive program, the national level repository launched in September. The state level repository launched in October. And since that time, we've had 208 eligible professionals and 14 eligible hospitals that have registered on the national side. You can see the numbers on the state side. And 2 so far have attested to meaningful use. So in addition to supporting the EHR incentive program to encourage adoption and meaningful use of EHRs, we are also working closely with the Hawaii Health Information Exchange, which is a state-designated entity for health information exchange. That's a key aspect to allow this to go forward. Transformation activities in the future. So here are some that are planned. We need to complete the implementation of KOLEA. Although we got it up, there's a tremendous amount of work that still needs to occur. So we'll be very busy working with that. A number of state plan amendments still to fully implement the Affordable Care Act. As you heard, to complete the transition to the Community Care Services Program, implementing Quest integration, and trying to expand our program integrity activities. Some potential opportunities that have been discussed out there. The patient-centered health home, this is one that we are very much committed to. We've put that in our budget, and we hope the legislature will support this so we can move forward with that. We've also put in our budget request restoration of adult dental benefits, which is something we hope to restore. State Innovation Model Testing Grant, we're supporting Beth Giesting and the Healthcare Transformation Office, and look forward to successful application. Would like to work on addressing those quote-unquote frequent flyers or super utilizers through innovative approaches, including an ambulatory ICU. There's been discussion in meetings on a Medicaid buy-in program. Basic health is out there. And the opportunity of looking again from what we heard earlier is how the state can really leverage its purchasing power. So those are some of the things that we're just diving into and have a whole lot more work than we have resources. So in summary, enrollment growth, 38% during that 5-year period. We've expanded benefits, we've improved health and decreased cost, and improved patient experience. But there's still lots of room for improvement, and we need your partnership to continue to improve the work that we do. Many thanks to our stakeholders and partners. Our success is really due to you. So thank you all for your participation. Hold your applause. We're going to do questions in a minute, but I'm going to rapidly jump into this Commonwealth Fund report. So the Commonwealth Fund report on health system performance for low-income populations defines low income as less than 200% of the federal poverty level. They based it on 30 indicators in 4 categories: access and affordability, prevention and treatment, potentially avoidable hospital use, and healthy lives. Each indicator was weighted equally within the category, and each category was weighted equally. These were the data sources. Okay, so this is the first category, access and affordability. Hawaii, which is hard to see there, is because it's in the top quartile, which they gave white to. You can see some of the other states that are top performers. This is for rates of uninsured, and on the left is for adults and right is for children. Hawaii ranked second in the nation for having the lowest uninsured rates for both adults and for children. According to this report, for children, it was 5%. For adults, it was 21%, which we would say is pretty high, but that's actually the second lowest in the country. Prevention and treatment. This is one where we actually ranked in the second quartile. The measures where the indicators for which we were below average on this one included older adult preventive care, surgical care to prevent complications, hospital 30-day mortality, hospital discharge instructions for home recovery. Now these data are a couple years old, but these might be areas that we want to look to work on to improve. Potentially avoidable hospital use, which I would think is a reflection of access to care and outpatient care to keep people out of the hospital, top quartile. Looking at this, you can see Hawaii actually ranks best in the nation for potentially avoidable hospital use for ambulatory care sensitive conditions, and for second in the nation for the lowest rate of potentially avoidable emergency department visits. The blue dots there are your duals, those who are eligible for both Medicaid and Medicare. Healthy lives, Hawaii top quartile. Hawaii ranked best in the nation for low-income folks for having the lowest percentage who report their health status as fair or poor. Okay, so that's good work. So the overall summary for the nation, you can see Hawaii ranks in the top quartile, and you get a sense of the other states that also rank highly. And when you dig into the details, Hawaii is ranked #1 in the nation for having health system performance for low-income populations. And I know that you're clapping for yourselves because we could not have done it without you. So thank you for all of your help.
Thanks.
Okay, we're going to dismiss with the cards for the Q&A. There's a microphone, I think, over here in this aisle. Because of the, so if you have a question, queue up. We'll try our best to answer it, and but we're also, just because we're really running short of time, would ask that nobody ask a question longer than 2 minutes. So it'd just be like way too much for us to handle. Okay, is that Lauren?
Yes, it is.
Lauren.
Good morning, Patty. I'm happy to see that a restoration of adult dental benefits is on the offing in the potential ideas. But can you comment generally on how and if access to children's dental services will be affected by 2.0? Are there planned PIPs for this? Will there be increased reimbursement, like, for example, for primary care providers and pediatricians, similar to preventive dental services, dental homes? Are they going to be incorporated as part of your patient-centered medical home model?
So for kids dental, Insure Kids Now. So we actually have to report to CMS looking at access to dental care, and Hawaii actually ranks quite highly on kids' access to dental care. Again, many thanks to our dental providers. The other thing we've done, though, to expand access was we recently issued guidance that beginning January 1st, we're going to expand access to topical fluoride varnish. So currently, it can only be provided by a dentist, but we will now cover it if provided by a primary care provider as well. Children's oral health is very important to us in Hawaii, where there's almost no public water fluoridation, which is an effective preventive measure, as you know, from a public health perspective. So we're certainly doing what we can. So today, kids have full coverage for dental benefits, and we continue to do what we can to improve access to oral health care.
Hi, Dr. Kimball. Do you have a question?
Yeah, I'm still running into a lot of problems with what I consider to be unreasonable and inappropriate formulary restrictions. I had to do prior authorizations for amitriptyline earlier this week, and that's one of the cheapest possible generic drugs that's been out forever, and they wanted me to do a prior authorization for that. And there seems to be no way to influence the health plan's policies on their formularies and pharmacy benefits to resolve this. And this is also has something to do with why a lot of doctors are not taking Medicaid still, who might otherwise take it if it were less frustrating.
Okay, thank you, Doctor.
I know there's been some confusion in the past that these plans have multiple products, and it's important to know if these are Medicaid coverage, Medicare coverage, because there has been some confusion. So we certainly will welcome feedback. We've had many conversations to understand improvements that we need to make on the Medicaid side. It's real important that we actually understand the root cause of the problem if it applies to Medicaid or Medicare. As you know, from a Medicare side, we have no control over Medicare. But from a Medicaid side, we welcome feedback that we don't know unless we get feedback from providers, beneficiaries, other community members, how we can improve the programs. And again, the changes we've made, if you look at our recent procurements, we made a number of changes, really, which have been initiated by the community. So we really welcome your feedback. We're happy to give out our phone numbers to let us know, how we can improve our programs.
Mark? Hi.
No, Scott.
Oh, Scott, excuse me. I'm sorry,
Pat.
Scott.
Given the shortages in the professional workforce, what are the possibilities for paraprofessional medical workforce expansion?
Peer-to-peer.
You want to do that? Want to do that?
So for Medicaid, it's very difficult. We have to follow federal rules and regulations, and one of the things that was part of the, that came out of the Affordable Care Act actually was that all of our professionals that we, provide compensation for have to actually be licensed. And so one of the things that MedQuest has done is we have recognized that there are professionals that are providing, excellent services that are not licensed, and we've actually gone and asked special permission to be able to provide compensation for those individuals. So one of that group is peer specialists, and I spoke about that earlier. That's a certified group. We're also asking for certified substance abuse counselors. And, we're really open if there are other, groups that have some type of a training or certification for us to be able to provide compensation for. But the Affordable Care Act really did, really narrow what we can do, but we can ask special permission. So if there's other groups other than, certified peer specialists or certified substance abuse counselors that the public would like us to do, we'd really be very interested in that. Both of those actually came from, the community to actually make those recommendations to provide coverage for.
And I want to acknowledge Scott's leadership in helping the department to open its eyes to the value of peer-to-peer specialists, and your comments on that certainly enabled and emboldened us, if you will, to expand to peer-to-peer in the behavioral health. So thank you. The community advocacy is very much appreciated. Thank you. Okay, Representative?
I apologize if I missed this announcement, but since KOLEA has been up, what are the numbers we're seeing in enrollment for Medicaid?
So, thank you. There's been approximately in the first month, but who's counting? In the first month, we've received a total of 8,373 applications through the KOLEA system. And this is what's fascinating to me. 4,070 of those were online applications, which tells me that Hawaii really is engaged, wants to use this new electronic tool, and I think as time goes on, we will see more and more people engaged in the IT system. So little short of half of those were online. Of those 8,000 applications that we received, approximately 213 were Medicaid eligible. Excuse me.
Sorry. So there's.
So approximately, of the 8,000, let me reverse this. Of the 8,000, approximately 2,900 were Medicaid ineligible. Those case files were sent over to the connector. Now, when we say there were 8,000 eligible Medicaid applications, I can't, it may not, some of those applications who were eligible may not be new applicants. They may have been people who rolled off and who are rolling back on. And so I think we're really going to have to track the census out a little bit for a couple of months for us to be able to trend net increases in the overall enrollment rate. But KOLEA has been well received by the community, and the community is engaged in the process. I hope that answers your question, Rep. Before you get a second bite at the apple, is there anybody else who has any questions? I don't want to deter other. Okay, Dr. Kimball, it's yours.
Right here.
Oh, excuse me, we have one over here. Thanks. If you could just wait a second.
One important thing that helped me, I'm a pediatrician up in Kona, and I have a large Medicaid population. One thing that helped a lot was the placebo program that HMSA Quest has up and running. I was able to improve my scores, my HEDIS scores, beyond the 90th percentile on all categories except one. It would be appropriate or helpful if your department could encourage the other providers to get on the placebo program, because that's the one that seems to be working the best, at least for my solo practice. I know another Quest program.
So Kenny will repeat the question, but Doctor, thank you so much, particularly on the neighbor islands. I know some of our clients struggle to find participating physicians, so thank you.
The question was, as a solo practicing pediatrician trying to basically do some population management, improve quality, that one of the tools is a COSEVA product that he's using that to find very effective. So it's a great example of how health information technology can help improve quality and efficiency of care. And what can we do from the MedQuest perspective to, again, help providers and get alignment among health plans from a perspective of improving, how can we do a better job of supporting our providers, particularly regarding quality improvement. And that's something we'll have to think about and certainly figure out with the Hawaii Health Information Exchange where that role may be. Do you have an electronic health record? Do you have an electronic health record?
I'm starting it now, but I
Okay.
find that it slows me down.
Yeah.
So I have dual, my fever, as well as EMR.
Right. But thank you very much for your service to our beneficiaries and for the feedback.
You know, I'm sorry, I just got the 0 time left, but I do see that there are speakers or audience members lined up. We'll be available, we'll remain here, and we're happy to answer your questions. But thank you so much for your participation. Thank you.